In this first session on day 2 of TIO, we're going to be talking about complex calcified lesions, and I'm delighted to be joined by an esteemed panel of friends, colleagues, and world experts. We have Azeem Latib from New York. We've got Margaret McEntegart from New York as well, Giuseppe Tarantini from Padua, Italy, and Holger Thiele from Leipzig in Germany. As I mentioned before, this session focuses on coronary calcification, and we're going to start first with a poll, a somewhat provocative poll. What would the next large PCI randomized trial be about, ideally, in your estimation? Now, we're kind of triggering you to think about calcium, but I want you to answer it openly because there are several options for this. First option would be invasive imaging-guided versus angio-guided. Next would be a drug-coated balloon versus a drug-eluting stent in all-comer patients. Next would be dedicated calcium modification versus conventional balloon preparation. Another one would be single antiplatelet therapy versus DAPT. And then the last one, every list for tests, 10 to 15 years, multivessel PCI versus CABG. So please take some time to vote online. We're going to come back to that poll later, but I'd be curious to see what people think. I think we'll start first with a lecture, and we're going to have Holger Thiele, who's recovered his voice and is ready to talk to us about myocardial injury prevention, also voice recovery too. And why don't we go ahead and start with that presentation and have some discussion as well. Thanks so much, Holger.
Yeah, thank you, Ajay. I really try to do set the stage now for the panel discussion we have afterwards. And when I got this title of this presentation, I thought, oh, myocardial injury prevention. This is something dealing with acute coronary syndromes with ST elevation MI. But for sure, this is not the topic I will try to cover. But nevertheless, we can learn from what we have done in acute coronary syndrome. Maybe we can transfer this also for chronic coronary syndromes and for complex PCI lesions. So we know that paraprocedural MI in chronic coronary syndromes is related at least to mortality at longer follow-up. As you can see it here, this is one from the Munich group, one publication. But as you all know, only troponin elevation after an acute myocardial infarction, this is not the real answer. So we have different classifications for the measurement of paraprocedural MI. So we have the third universal definition of MI, we have the fourth universal definition of MI, we have the Academic Research Consortium 2 definition, and we also have the Society Cardiovascular Angiography and Intervention definition. And as you can see it here, the thresholds are always different in all the different definitions. And also some require ECG changes, some also require symptoms, whereas some others do not require symptoms. And this is a lot of debate regarding the optimal.
I think we lost.
So it looks like we have a little. Okay. Yeah, we lost Holger for a second, and he was setting the stage nicely for what was going to be a talk on, myocardial preservation, and part of the.
So
I think that the feed is a little bit unstable, so it might be worth correcting that. Holger, can you hear us now?
Yes, I can hear you. So I had some connection problems. I'm really sorry. Maybe I can.
No, it's okay.
Once again.
Yeah,
yes.
Perfect. So we lost you right about where you're talking about the clinical criteria, but I think many people know that. So maybe pick it up here and then we'll continue.
All right. Yes. Sorry for all the technical problems. So as you can see it here, probably the highest prognostic information we get from the SKY and from the ASC2 definition for paraprocedural MI, whereas the third and fourth universal definition of MI is only borderline related with prognosis, as you can see it here from this very nice analysis which has been published 2 years ago. This is what I mentioned. So we have learned a lot of about cardioprotection in acute myocardial infarction with different options. So we can do pharmacological conditioning, we can do cooling, post-conditioning, remote ischemic conditioning, and we can also combine different devices to prevent myocardial injury. This is what is all available. And also from experimental models, we know that drugs play an important role, maybe also filters may play a role. And then there are lots of a huge variety of different options on trying to improve myocardial salvage in acute myocardial infarction. Very nice publication also on interventional options. This is what we discussed later on. With filters and distal protection devices, we always have used or tried to prevent myocardial injury after acute myocardial infarction. Now coming to antiplatelets, probably they are important for the prevention of myocardial injury or maybe also periprocedural myocardial infarction. And in particular, during the early phase, we need optimal antiplatelet inhibition in these patients. So because we also have local ischemic events and also we want to prevent systemic ischemic events. This is what we have all available. This is what you all know. And in particular, we are addressing oral and intravenous and P2Y12 inhibitors. There's one small trial, interesting trial, also from the Munich group, Sasikaya trial. As you can see it here, they were comparing patients undergoing elective PCI with a loading strategy with prasugrel in comparison to clopidogrel. And as you can see it here, there was no difference in the primary composite endpoint between an intensive loading versus standard loading. And as you can see it here, also any myocardial injury or infarction was not different between the more potent P2Y12 inhibitor prasugrel in comparison to clopidogrel. And as you can see it here, this is also nice to see. There were no differences in periprocedural MI between the two groups in this trial. But this trial only used so-called low-risk PCI, low-risk lesions. And the myocardial injury and infarctions are dependent on the complexity of the PCI. As you can see it here from this Champion Phoenix sub-analysis, as you can see it here. The more complex lesions you have, the higher the risk of myocardial infarction and the higher the risk of stent thrombosis. This is clear and this is evidence, but this has been shown in this publication from Greg Stone. So by cangrelor, the even more potent IV P2Y12 inhibitor, we can reduce myocardial injury and myocardial infarction and also stent thrombosis, as you can see here, in stable ischemic heart disease, as well as in acute coronary syndrome. So very potent P2Y12 inhibitors, they are able to prevent myocardial injury and myocardial infarction. And this is what the topic now for today, lesion preparation in calcific lesions. And this is what we have available for our instrumentarium. We have rotational atherectomy, orbital atherectomy, scoring balloons, non-compliant balloons, OPN balloons, cutting balloons, and also low-profile balloons. This is all available. And I just cite in the next slide, as you can see here, a nice work from Margaret McEntegart regarding how often we see periprocedural MI in patients undergoing rotational atherectomy. As you can see it here, 4% had troponin elevation more than 70 times. And you can also see that 70% of the patient had a troponin elevation more than 5 times, according to the universal definition of MI. So a lot of patients having periprocedural injury and necrosis. And this is also even seen in roughly 20% of the patients in MRI, as you can see it here. That's the reason, maybe setting the stage. This was in the poll we had. So do we need randomized trials for calcified lesions? So this is a trial which is currently ongoing, the SONAR trial, comparing patients with calcified lesions to rotablation, 85 patients in comparison to shockwave IVL, well, once again, 85 patients. And they are looking for the primary endpoint, procedural MI and periprocedural injury, as you can see it here. And with this, I would like to stop, summarize that periprocedural MI is relatively rare, But the more complex the PCI is, the higher the risk, and the highest rates we probably have in rotablation. There are different ways on how to measure it, as I've shown to you with all the different definitions. Intensified antiplatelets, in particular IV cannula, is able to reduce per-procedural MI and stent thrombosis. And if we have device-based prevention strategies, this has to be shown in further randomized trials. And by this, I would like to thank you and looking forward to the discussion.
Holger, that was a great presentation, and I love the way you tied in the overall topic with the specifics of calcified lesion preparation, because that's kind of what we're here to talk about. And one of the reasons why this was on the agenda in the first place was because oftentimes we view this as just part of the price of doing business. You're just treating a calcified lesion, and this is going to happen. But this question, is it important to prevent? Are there strategies to prevent it, or is it inevitable? Is maybe one that I'll sort of ask to maybe Margaret, if you could start off with and tell us a little bit about how you put that in the context of the study that you published, showing that this rate of troponin elevation is not insignificant. Is it inevitable? You just have to do it, or what do you think?
Yeah, so thanks, Holger, for showing that data. So yeah, it was quite an interesting study. So essentially what we did was we took 50 sequential very kind of complex calcified cases that required rotablation, and we was quite involved in that. What we did was they all had MRIs on the morning of the procedure, then went on to have their complex PCI, and during the course of that, they all had physiology done at baseline, post-rotablation, and at the end, and they all had IVUS done at baseline, post-rotablation, and at the end. And we're really kind of trying to look at this whole question about periprocedural injury, and then they all had an MRI at 7 days and 6 months to look at injury. And as Holger said, that there was a very high instance of troponin rise, 5 times the URL, and also 24% had a type 4 universal definition MI, whereas the SCAI definition was only about 4%. And interestingly, on the MRI, all the patients that had universal definition MI all had edema on the MRI, but most of that resolved at 6 months, with a smaller proportion left with some LGE scar, showing they'd actually had a significant injury. So it was quite interesting. The other interesting thing was that the physiology. So what we saw was immediately post-rotablation, the IMR went up. But by the end of the procedure, when we remeasured it, in the majority of patients, it had normalized by the time you had finished your stenting and optimization at the end of the case. So I think it's kind of interesting to reflect on that, what we could do periprocedurally to try and avoid that or to reduce it. And as Holger alluded to, I think in the calcium space, that may be around different choices of different devices in different situations.
No, those are great perspectives. And I think that it's also consistent with prior data that showed that if you did sort of SPECT immediately post atherectomy, you may see defects, but then they resolve typically over time. And those wall motion abnormalities you sometimes see on echo as well. Interestingly, there also, by the way, is a disadvantage sometimes to using non-atherectomy devices, because you may need to use more guide extensions, you may need to use longer balloon inflations depending on the device. And so this study, like the SONAR trial, is an important one to study that exactly. Azeem, any thoughts on this? And maybe then we'll have Giuseppe give his thoughts.
Yeah, no, I agree. I think, we've always known that when we do procedures like atherectomy, there's going to be some sort of distal embolization, and there may be some sort of enzymatic release. And I think in many centers, we've stopped actually measuring cardiac enzymes because small rise in troponin were not clinically significant. But I agree with you. We should be careful not to sort of push it in one way or the other. I see many cases where people don't do rotational atherectomy, and now the procedure is so much longer. They're dilating with multiple balloons, and they're causing repeated ischemia, which probably causes as high a troponin rise, if not more. So I think, using these tools appropriately are important, but I think what this highlights as well is there's still this opportunity to do even better. And maybe, we're not done with how we modify calcium, that there are potentially other devices on the horizon that will allow us to manage calcium without maybe some of these downsides.
Yeah, I agree entirely with your point about collecting biomarkers, and we don't do it routinely. And in fact, the troponin assay is invariably going to be abnormal. So that's one of the reasons why these other definitions like ARC2 and even the fourth universal definition, as opposed to the third, incorporate the clinical factors in addition to the biomarkers, because the biomarkers alone might be abnormal. Maybe, Giuseppe, I'll ask you just briefly, how do you put this in perspective of a spontaneous infarction? Is the prognostic value the same? Is it worse with this than spontaneous? And how do you weigh that, perhaps if you're even telling the patient about what happened? I think you're on mute right now.
This is a very difficult question, to answer in a definitive way, but actually I have a consideration to do. Actually, when we look at all the studies presented by Holger, actually they belongs to an era where we didn't use so many debulking procedure. We don't have so many techniques like in 2024 to treat this patient. And actually, in the absence of branch losses, and that was the vast majority of these cases, actually this might be a surrogate of the way we perform the PCI. This is a surrogate of the plaque burden in these patients. So actually, I think what we need to see as a new data, if the use of new technique, let's say plaque modification, things like that, may change this relationship on top of the fact that the plaque burden, the symptom score, the residual symptom score is the same. So in other words, we need to understand if the new technology can change this kind of relation, increase the amount of the increase of the troponin and myocardial damage and its relationship to the outcome, because at the end we have to admit that the outcome is mainly grounded at 1 year. So if we have a major problem in the acute phase, we should see the adverse outcome at 1 month, but actually we used to assess it at 1 year. So actually I think this in 2024 we need to understand if the way we tackle these patients with this new technique may change this relationship.
Really, really great points. And to that question of spontaneous versus paraprocedural, in general, the prognostic value of a spontaneous myocardial infarction is even greater, even if you think about hypersensitive assays that we have nowadays, than that of a paraprocedural event. And I think most clinicians don't typically check routine biomarkers. Now, if there's EKG changes, as you said, branch loss or things like that, that's much more relevant, and then that clearly has prognostic value as well. I'd just like to remind the audience that if you have any questions, definitely send them in through the chat as well. We'll try to get to them if we have them. But if not, I think it's probably sufficient to go ahead and talk a little bit about what the devices that we have might be to treat coronary calcification. So we'll move on to Margaret, who's going to give us a talk on decision-making, what tools for what lesion, and we'll send it over to you.
Thanks, Ajay. So I think this conversation around which tools for which lesion really kind of got stimulated probably about 6 years ago when IVL became available widely in the UK and Europe. And I think, round about that time, it really got a lot of us starting to kind of debate amongst ourselves about when we should be using which of the different technologies. And around about that time, there was kind of an explosion of algorithms to guide our decision making. And this, I was looking back through my old presentations, and this was one of our first kind of drafts of the UK algorithm of how to manage calcium that we put together in 2018. And there was, off the back of this, there was multiple algorithms that came out of Europe that have been published and presented, and then obviously also here in New York in the US. And then I think over time, over the kind of 6 years in between, as we've all gained much more experience with IVL and also orbital, and with wider availability of the other specialty balloons, our kind of thinking and knowledge around these decisions has developed. And I think in parallel with that, the expansion of the use of imaging increasing our understanding of the different morphologies of calcium that we face in these lesions, and also the differential effects of all the different devices, really has evolved our thinking around that space. And you see that as the algorithms evolve, they've become more and more and more complicated. So this was kind of the last version of the UK algorithm, where you see that we're thinking about calcium morphology, we're thinking about lesion morphology, we're thinking about lesion location, and it becomes a very kind of complex, kind of very specific decision-making process. And it's interesting now, with some years, to reflect back on that, how focused we were on the details about the lesions and the morphology of the calcium. Over kind of the last 2 to 3 years, with the availability of IVL in the US, and you see here, this is the NCDR data from last year, and you see IVL in the orange bar. And what they interestingly showed that by the Q4 of 2022, over 50% of calcium modification procedures in the US used IVL as the first device. And while IVL use has grown in the US and also orbital now in the UK and Europe, and also with kind of wider availability of all the different other specialty balloons, despite all this experience, I think that we still are at the same question 6 years down the line: which tools for which lesions? And I think it's interesting, with all the very specific algorithms we've used over that time, to now reflect on the fact that some of the more recent algorithms, and this is the algorithm from the recent SKY consensus document that I was involved with, the more recent algorithms that are actually becoming less device specific. And you see here that in this algorithm, we advise that you use imaging as early in the procedure as possible, as was in all the other algorithms, that you consider all the criteria for calcium severity. So have you got a 360 or 270 arc? Have you got a nodule? Is your vessel less than 3.5 millimeters? Do you have thick calcium more than 0.5 millimeters? And then if you have these criteria, you're asked to consider to use one of the calcium modification technologies, but the advice is much less directed and less specific. You're also asked to consider, are you dealing with diffuse, long diffuse disease or focal disease? And again, to reflect on whether you've got concentric, eccentric, or nodular calcium. But as I say, much less device specific. And I think this is really a reflection on the fact of the kind of wisdom of the more you know you don't know, and the less dogmatic you've become. So I think it's kind of interesting that I myself, and I think the complex PCI community in general, has become a little less dogmatic about which device for which lesion. Now, we've been talking about which tool for which lesion, but the other thing I think that's become very important in our practice is actually to think about which tools for which patients. So I think we've started to understand that beyond understanding the morphology of the disease, we also have to step back and look more widely at the patient. And if we consider these two scenarios, so say we have a large calcified nodule in the left main bifurcation, and in one scenario we have a 55-year-old patient who's fit with no comorbidity and preserved LV, but on the other hand we have the same lesion in an 85-year-old patient who's frail with severe LV dysfunction and CKD. Our approach and our strategy in these two cases should be different. So we have to look beyond the lesion morphology, and we have to consider the patient as a whole as we decide how we're going to proceed with the management of these two very different patients in very different scenarios. So if we go back and think about what our upfront strategy might be in these two patients. So if I'm looking at the 55-year-old, I'm thinking ahead of time. I'm going to use imaging as early as possible in this case, and I'm going to use either IVUS or OCT. Both would be fine. I'm then going to have quite a low threshold to use atherectomy, thinking that I want to try and reduce the volume of that nodule and modify the calcium with an atherectomy device. I'm then going to re-image, and I'm going to again have quite a low threshold to use another type of balloon-based technology, either one of the specialty balloons or IVL, really to make sure that I have maximized my modification of that calcified nodule and the associated concentric calcium to make sure I'm going to get a durable result for that patient. So with a 55-year-old patient in this type of scenario, we're looking to get a 20, 30-year durable outcome for that patient. Now, in the other scenario with the 85-year-old patient, I'm thinking less is more in this scenario. I'm going to use IVUS to avoid using any excess contrast that's not necessary. Once I've done my IVUS, I'm going to try and do something, take the most efficient path to get a good enough result. And that may well be a decision pragmatically just to go straight to IVL. I'll probably repeat my IVUS just to check I think I've done enough, and then go on and complete the procedure. So I think the important thing in this scenario is to think about the fact that in this 85-year-old patient, we're looking for a kind of shorter term result than we're looking for in that 55-year-old. And there's no point in us getting a beautiful angiographic or IVUS guided result in this patient if in the process we've caused hemodynamic collapse, the patient gets MCS, we give them a vascular complication, or they get AKI, end up in renal replacement therapy, or even worse, they don't survive the procedure or survive their hospitalization. So in the 55-year-old, we're thinking predominantly, I'm going into this case, thinking predominantly about efficacy, getting the best PCI result for this patient. And I'm aware of risk, but I'm less concerned about safety, because in this patient, the risks of the calcium modification in the procedure are lower. Whereas in the 85-year-old, I'm very aware of risk, and my predominant focus here is on safety for this patient and getting this patient through this procedure and getting a good enough result for this patient, and not striving for better. So really, to summarize, I think it's interesting to reflect on the fact that our early algorithms were very lesion morphology focused. With experience, our understanding of the effectiveness and safety of each of the modification devices has evolved and continues to evolve every day in our clinical practice. It's interesting to reflect that with that, the more recent algorithms are becoming less device specific. And I think the key here is for us to focus on each individual patient and to find that optimal balance between efficacy and safety that's in that patient's best interest. I think patient factors are as important as lesion morphology when we're deciding on our procedural strategies. Thanks.
Margaret, as always, that was very thoughtful and data-based, but also very clinically grounded, which is something I get to experience every day in working with you, but I don't know if everybody else does. So it's really nice to see that perspective showcased here. Maybe I'll ask, Azeem some thoughts just generally on this concept of, integrating in the patient characteristics with all of the other characteristics, because we've seen that honestly on the structural side pretty overtly. When it comes to patient risk, it completely can change your approach. But I think more recently in this chip era, we're seeing it more addressed on the coronary side as well. It's always been part of our practice, but I think some overt recognition of it's important. You feel the same way, Azeem?
Yeah, absolutely. Firstly, I want to congratulate Margaret on the presentation. This was like really one of the most practical, pragmatic presentations on calcified lesions I've heard in a while. And it was understandable by everybody. So a couple of things I took away from her presentation, which I want to highlight again because I liked it so much, was moving away from these algorithms that I couldn't follow, to be quite honest. That was so complex because they could go in so many different directions. And we all knew that most of them were just based on more opinion than data. So going to a more pragmatic approach that's not about the device, I think is fantastic. I also, love the fact, and I think that has to be a take-home message for everybody. If you're going to do calcified lesions well, intravascular imaging is at the heart of that. To be able to know what to do, to be able to make sure you have a good result. Doesn't matter how old the patient is, that's at the heart of what we do. And so I wanted to just be repetitive about that because, the use of intravascular imaging is still so low globally. And then the last one, which also I love, I think for me is the biggest message that I try and give my team every day and try and teach is how do we look at the specific patient that, one procedure we may do on someone who's 55 with minimal risk factors is not the same procedure I'm going to do on my 85-year-old who has severe aortic stenosis with a gradient of 60 and has a left main. So how do we, be more pragmatic about doing the right approach for the complexity of that patient? I too often walk into a room and I get called about a case from a colleague, and they're taking on this super complex case in someone who's creatinine's 3, they EF's down, they're 85, they can't take long-term dual antiplatelet therapy. And I go, but hang on, we need to be more pragmatic about what our goals of revascularization in that patient is. So I do that all the time. And I think, structural, we're forced to do that because our outcomes can be very different if we don't. But I think having this sort of pragmatic approach where we once again put the patient in the center, not just the lesion, and, it's the patient first and then it's the lesion, is to me probably the biggest message I'm going to take home today.
Azeem, great points. And I think that we all know that I think one thing I want to emphasize to the audience is that this is not about getting away with an inferior result. This is about priorities for the patient that are equally as important as what the artery looks like at the end. And we all know there are people who are technical wizards who never see the patient in follow-up and really could care less about what happens afterwards. And those are not the types of people who you would typically send your family members to because you want them to be a complete physician. And so that's, I think, entirely what this is about. And thanks for refocusing on that. Maybe, Giuseppe, some questions for you on that I've noticed is that with this improved use of technologies across the board, we're starting to see other technologies that had been sort of dormant for a long time, things like cutting balloons, scoring balloons. There's more interest in the use of those. Do you find those of utility as well? Have you sort of re-looked at some of these in your practice?
Okay, thank you for this point. So actually, sticking to the comments of Azeem, first of all, it is for sure that the indication is mainly based on the patient, but actually the point is that because the feasibility of a lesion or treating a lesion is never an indication to perform it. It's mainly based on the patient. But actually, when we decide that the PCI is indicated, actually we need to face to the fact that based on imaging, we have a severe calcification, we need to decide what to do. So what is my experience in Italy, in my center, etc.? Actually, depending on the imaging, on the quantitation and qualification of the calcification in a lesion, we decide to move differently. Let's say we don't use as a first line the cutting balloon. Actually, what we use is rotablation when you're not able to get through with the balloon. Actually, we go as a first line with the rotablation or orbital, or a device that permit to get through with the other devices. The way around, when we might get through with the balloon, etc., we prefer to go shock wave or laser, depending on the type of the lesion. So actually, when we have a huge calcification, let's say 90% of the lesion is calcified horseshoe or 360 degree, I prefer to go with shock wave because we have evidence that you can crack better with a shock wave. But actually, when we have a mixed tissue, this calcification plus fibrotic tissue, or you need to post-dilate the stent, etc., the laser, the grenade PCI works very well. So it depends on the lesion. At the end, the lesion matters when you have already decided that this patient has to be treated.
So great points. And I do think, at least personally, we have started revisiting some of these other adjunctive technologies because, oftentimes they'll work. And certainly there are specific scenarios like ISR where there's less slippage and things like that. But even in calcified lesions, there's some emerging data that in many subsets that you can effectively get a fracture. And one of the nice things about the algorithm that Margaret showed at the end was that a lot of what we see is going to happen is predicated on getting a fracture in the calcium so that you can then expand your stent. And I'll be talking a little bit about that in my talk on the need for randomized trials. But Margaret, once again, thanks so much for that presentation. Unfortunately, Holger couldn't hear it because he's going to be doing a live case, but I'm sure the themes will resonate throughout all the talks and cases that happen later today. So if you could bring up my slides, I'm going to be talking about the need for randomized trials with not just atherectomy devices, but any device for calcium modification. Because of this issue, exactly as was pointed out by all of our panelists, that we don't really know necessarily what the best therapy is, and that the more we do know, we start learning a little bit more. And so I'll show you a case as well that illustrates that. I don't think I have to tell many people in the audience about the fact that with coronary calcification, it makes your case much more difficult to perform. It's harder to get stents, it's harder to get balloons down, you need more supportive wires, supportive guides, etc. But what's important is that there are also increased procedural complications, not just the type that Holger talked about, but in the data published on calcified lesion subsets, these are patients that have a higher rate of stent thrombosis and certainly higher rates of restenosis, practically the highest rates among any patient subset we see. So we really have to do a good job when we're treating these. You saw a slide like this before. There are many options now. And as an interventional cardiologist, what I think is great is that I have a lot of tools at my disposal. There's some folks who always use one tool or always use one tool for other specific cases. What we tend to do in our lab is we try to use different tools and then understand what the relative attributes are of each of them so that we're very flexible in terms of our approach. But that doesn't change the fact that we often don't know what the best thing is for an individual patient. And if you look at the guidelines, there's basically no device that has a class 1 indication for calcified lesions. Many of them are just class 2, oftentimes class 2B, and that's because there's been a paucity of randomized trials. One of the challenges with that scenario, and I seem to have lost my slides, but I can keep going on it, is that when you don't have randomized trials, oftentimes you're really just going with personal opinion about what's best for individual patients and beyond. And the challenge with personal opinion is that it often gets refuted by randomized trials, especially in clinical practice, when we really notice that that in the cardiovascular space, we rely upon randomized trials to actually inform our clinical decision making. This is not just going to be about personal opinion. So because I've actually lost my slides, I guess I can continue. Do you still hear me, by the way? Is it just a slide issue, or is
Yes, we do.
Yeah, we hear you.
out as well?
Yes.
We hear you.
Looks like the vocal is out as well. You hear me?
I hear you, Ajay. So, Azeem,
Yeah.
there's obviously a couple of RCTs underway or just completed recently. So we've got Eclipse, which I understand hopefully we'll see the results of later this year of orbital versus balloon based strategy for calcium. And then obviously we've just started recruiting to Shortcut, which is an interesting study where patients get randomized between IVL and the cutting balloon, and they can either have had upfront rota or not. So I'm kind of eagerly anticipating the results of those. What's your thoughts on the trials underway and the gaps that we still have?
Yeah, no, absolutely. I think if you ask me about the two, I'm more excited about the cutting balloon versus IVL. Because I think a little bit, you know, we never really understood how cutting balloons work, and I think only recently have I come to realize that they high pressure balloons rather than balloons that are going to cut the vessel or you know, that those blades actually tear vessels apart. So I think that study is going to be really interesting because I think there's a lot of mechanistic data now that's become available in relation to how cutting balloons work. I still think, you know, we need more devices. You know, I think you're going to be one of the PIs, if I'm not mistaken, for the fracture study, right?
Yeah.
Which is a study with a new device that does IVL, that instead of electricity is laser based and has a quad emitter, so you can really get your shock waves almost 360 around the artery, which to me is one of the reasons why we've had non-predictable results in eccentric lesions and nodules with IVL. So yeah. I'm excited about both. Maybe can we find the use of a device we've had on the shelves and is not that expensive and find out, you know, can we use it safer in more patients? But also, everybody loves IVL. Let's face it. It's easy to do. It works, but it doesn't work in everybody. So could we have other IVL devices that will make it even easier and more efficacious? So that's what I'm really excited about.
Yeah.
Can I say something? What's, Margaret, you think should be the primary endpoint? Should be the extent of myocardial injury when you compare technology, for instance, in a single vessel disease calcific, or what?
It's a really interesting question, and I think Ajay might be about to address that. Are you, Ajay?
I guess I'm back, so at least that's good. But yeah, maybe what I'll do is I'm just going to give the second half of the talk really quickly, and then we can go back to the discussion, because I like the way the discussion was going from what I heard. Look, the key is we don't really know what's best for individual patients, and what we do know is that if we're able to image sufficient calcium, and I see this as a problem because I think with the increase in imaging, which is great, there are a lot of people who are not experienced imagers, and they see a little bit of calcium, and then they assume immediately that they need a aggressive plaque modification strategy or a costly plaque modification strategy. Whereas in point of fact, what many of these algorithms tell us is that when an NC balloon is not enough, if you have severe circumferential long length calcium. But what the corollary to that is that means that NC balloons or other devices, scoring balloons, cutting balloons, et cetera, may work in many cases where calcium is detected. And so this is just an example of a case, calcified LAD. I'm not going to belabor it, but it was certainly calcified in that LAD. This was a patient actually randomized in a clinical trial called the Eclipse trial of atherectomy versus conventional angioplasty, randomized to the balloon arm. And so initially you often groan because you think it's going to be worse. Whereas in point of fact, what happened in this case is we pre-dilated and then imaged after pre-dilatation to see if there was a fracture. And when we image, I think if you appreciate the longitudinal view there's a segment that's still not well expanded. In this segment here, there's dissections and good preparation. But right here, there's circumferential calcium thick and it didn't expand. And so the question is that what many people are doing in clinical practice? The answer is no. Many people would just put a stent in, it would be underexpanded. But because in this particular case, and this is our practice at Columbia, I imaged that, saw that, went back a little bit more aggressively with an NC balloon, actually fractured the calcium, then put the stent in and post-dilated, and got a very good result by OCT, and I won't show you the whole image to illustrate the point. But so then the question is was a balloon enough? Well, the way I did it, I think it was okay, but the way that most people use balloons in clinical practice, they're not going to go look and see that they had an underexpanded segment, and then they're going to end up with an underexpanded stent. So this is why these trials can be difficult. But I do think in cardiovascular disease, we're used to randomized trials. Yes, we're experiential human beings and we know what we see in the lab, but it is important to do trials. And the reason that we want to do it is to try to understand what upfront makes the most sense. And so there are different designs. You can use a device versus a conventional balloon or specialty balloons. And then you can use device versus device trials. And in terms of endpoints, you want to basically think about the things that matter. Was this strategy successful? Were there complications? What was the size of the MSA that we achieved? And what were the clinical outcomes and economic outcomes such as cost? And there's a paradigm for this. Trials like Rotaxis looked at this, and although the overall trial was negative, looking at atherectomy versus conventional angioplasty, when there was severe coronary calcification, there actually was a greater strategy success seen with rotational atherectomy compared to the conventional strategy. Azeem actually referenced this because he's actually published this, and this is the issue of rota regret or atherectomy regret, where you might get similar outcomes, but if you go up front and do a planned atherectomy case, your procedure times are shorter, there's less slow flow, you get the case done efficiently, as opposed to really, really struggling along the way with balloons. And so I think we've all been in those situations, and that's one of the rationales for perhaps an upfront strategy. This is a large randomized trial that's completed enrollment, and we're planning on presenting this later this year. This is 2,000 patients randomized to orbital atherectomy versus conventional angioplasty for severely calcified lesions. And the important thing about this is we're going to be measuring, did the strategy work, what was device utilization, what were the costs, and what were the clinical outcomes. As I've told people, we don't know what the results are going to be, but certainly it should be informative, especially because we have a large imaging cohort. And then there are other trials like Prepare Calc, which has been published. We even have 5-year data now showing that upfront atherectomy, the strategy was more successful than using a scoring balloon, although overall both strategies seem to work. There are some head-to-head trials that are starting to come out. This is a single-center randomized trial of orbital versus rotational atherectomy. No overall difference in clinical outcomes. The burr sizes in the rota arm were a little bit more aggressive than many people use. The median size was 175. And interestingly, there was less slow flow seen in the orbital arm, but overall clinical outcomes were very similar. And the area achieved was greater with rotational atherectomy than orbital, but the burr size was bigger. There's also a trial called the shortcut trial, which is going to be cutting balloon versus IVL, looking at MSA as an endpoint, but also device and equipment utilization. And so we're actively enrolling in that and happy to support that trial as well. We heard about sonar too. So in conclusion, what's my point here? Well, my point is that we know we're seeing more and more coronary calcification in the modern day cath lab. We know this. And so I think as interventional cardiologists, as folks that are used to evidence-based medicine, we need to see randomized data, which will hopefully inform those algorithms. The reason we need to see randomized data in this subset is because these lesions are among the highest rates of complications that we see for coronary lesions, but because we should demand this as the gold standard for our field. But I would also say we don't want to be overly dogmatic in how we interpret it. If a trial is positive, it doesn't mean that that should be for every patient. If it's negative, it doesn't mean the device doesn't work. It's really the devil's going to be in the details of how successful the strategies were, how efficient the cases were, how safe they were, so we can always be patient-oriented in our focus. So sorry for the internet interruptions here, but I'm glad to see that it was able to come back, and maybe we can have some discussions at this time. We have a bunch of questions coming in. The one that everybody always asks about, calcified nodules, which device is better? And I would just say, I don't think we know right now, but I'm curious to hear what others think. Maybe Azeem, start with you.
Yeah, I wish I knew when I see a nodule. I often, depending on where the nodule is, whether it's like a left main nodule or it's somewhere else, I usually end up using multiple devices, I've got to say. I have not ever been happy that just one device does the trick. So it's usually I'm doing atherectomy followed by either shock IVL or a cutting balloon. That's usually what I end up doing. But I think, that's still one of the most challenging lesions we see. And I go back to also the fact that even when you do a good job, you just published a case report, I think, from your team. And we've seen this as well now in 4 or 5 cases where you spend all the time, you do imaging, you do IVL rota, and you have a great job. And then 6 months later, that area is restenosed because the nodule continues to grow, right? So I kind of still feel we still have a lot to learn about nodules. It's maybe one of the toughest lesions we have in coronary arteries.
Yeah,
Margaret, what are your thoughts on that?
Yeah, so I think 2 things. One, like Azeem said, I think the insights that Akiko's given us recently about differentiating between eruptive versus fibrous nodules. So the eruptive ones being much more likely to break just with balloon-based technologies, and even often with a non-compliant balloon. And the fibrous cap ones where you really need to work harder at them to modify them. But the other side of that coin is the eruptive ones are more likely to re-protrude than the fibrous ones are. So you can treat the eruptive ones much easier, but they're more likely to come back. But the fibrous ones are more difficult to treat. With the fibrous ones, I wonder about whether we can, as I've kind of spoken to the IVUS guys about this, whether we can come up with some kind of threshold to guide how aggressive you need to be with the nodule, whether there's a proportional volume thing of almost like plaque burden, nodule burden in terms of protrusion that then says you have to do something a bit more aggressive to reduce the volume of it, to give us some kind of guidance in the same way we've used arc of calcium to give us a guidance as to when we need to deal with concentric calcium. So I wonder if as we move forward, we'll have more guidance along those lines.
Yeah, I think that's true. And certainly I've seen a lot of presentations where people authoritatively say, this is the way to treat the calcified nodule. And I think, once again, if you do this long enough, you will see that you can be proven wrong with all these things, and sometimes you don't even think that a balloon's going to work, and a balloon does a great job. So, Giuseppe, any thoughts on that as a whole? Not necessarily nodules, but also there's some questions in the chat about how do you size rotaburs and the technique part of it. How important is, beyond the device, is the technique you employ to treat specifically? Because I think that's actually a very important thing.
Yes, actually, as I said before, I used to go with the rotablation where the calcification is within the lumen, and actually I'm not able to cross the lesion. So actually in my practice, what I use is to go with the 1.5 just to create the way to go with the balloon, because actually there is an escalation device. If I have a severe calcification, 260 with very thick, etc., I prefer to go with the OPN or a shock wave. It depends on the lesion. But actually, if I have a mixed tissue that is calcific plus fibrotic, I prefer to go with laser. But actually, the escalation is the following. Rotablation first is if I'm not able to get through, with the balloon. And then if I create, a crack within the calcification, I used to go with the downsize of OPN balloon. I don't use the cutting, or the lithotripsy in case I see that I'm not able to fully expand the balloon.
Yeah, and I think there's a lot of people, some people like the cutting balloon there, some people like the Scoreflex. I think there's different practice patterns there, but the fundamental premise of, not necessarily having to debulk, but basically making a channel enough and a little crack enough that you can then facilitate everything else has worked very well. So lots to discuss. There's certainly going to be more data. Good news is that there are randomized trials that are ongoing in this space. So we're going to learn a lot more about calcified lesions going forward. So thanks to everybody for the talks, and thanks for standing through the technical difficulties. We're going to go on now to the session on live cases, because this is where we'll sort of see these things we've talked about theoretically somewhat actually implemented in clinical practice. So let's see you after the intro, and really happy to explore these cases with you.